මේ මොහොතත් සමගින් අපත් මේ මොහොතේ අපත් සමගින් නැත්තල් බැල සිටින මේ ස්ථානයේ සමගින් ඔබ සියලු දෙනාම සම්භාවනීය ආරාධිතව ගන්නැතුළු සියලු දෙනාම ආදරයෙන් ගෞරවයෙන් පිළිගනිමින් මේ පිළිබඳව අරමුණ පැහැදිලි කර ගැනීම කිරීම සඳහා ගෞරවයෙන් ආරාධනා කරනවා රජ ඖෂධ විභාගයේ සංගමයේ ගරු සභාපති තුෂාර රණදේව මහතා.
வரவேற்புரையை வழங்குவதற்காக அரசு மருந்தாளர் சங்கத்தின் தலைவர் மதிப்பிற்குரிய திரு துஷார ரணதேவ அவர்களை அன்புடன் அழைக்கின்றோம்.
I would like to invite Mr. Tushara Ranadeva, President of the Society of Government Pharmacists, to welcome you officially.
Every year, on September 25th, good evening ladies and gentlemen, every year on September 25th, we commemorate World Pharmacist Day to honor pharmacists for their contribution to enhancing the world health. Society of Government Pharmacists organized this event, this program, with the same objectives. For on this very special day, I warmly welcome our chief guest, Professor Vajira Disanayaka, President, Sri Lanka Medical Council, Dean, Faculty of Medicine, University of Colombo. Our keynote speaker, Vidya Jyoti, Professor Asita De Silva, Professor of Clinical Pharmacology, Faculty of Medicine, University of California, and former chairman of the NMRA. And all other invitees, including Dr. W.K. Veerasinghe, DDG, National Hospital, and all academics who are present here, Health Ministry officials, union leaders, other healthcare professionals, and fellow pharmacists. For this special event, thank you for presence here for sharing this special event with us. Thank you very much.
ස්තුතියි ගරු සභාපතිතුමනි. ඊළඟට සුවිශේෂී මොහොතකටයි අප යලිත් නියමක් කරන්නේ ලෝක ඖෂධ වේදී දිනයේ ප්‍රධාන උළෙල පැවැත්වෙන්නේ ඕස්ට්‍රේලියාවේ බ්‍රිස්බේන් නගරයේ. ඉතින් ऑस्ट्रेलियाවේ සිට ජගත් ඖෂධ වේදී සම්මේලනයේ සභාපති වත්මන් සභාපති පෝල් ස්ලික්ටර් මහතා සභාව අමතරව වීඩියෝ තාක්ෂණය ඔස්සේ මේ මොහොතයි.
இன்றைய நிகழ்வில் சர்வதேச மருந்து கூட்டமைப்பின் தலைவர் தற்பொழுது ஆஸ்திரேலியாவின் பிரிஸ்பேன் நகரிலிருந்து சிறு உரையை உங்களுக்கு வீடியோ பதிவின் மூலமாக வழங்குவார்.
So on this World Pharmacist Day, September 25th, 2023, I'm here in this break. To celebrate the World Pharmacist Day with the 5 million 81st Congress of FIP. So I take this opportunity to congratulate all the pharmacists in Sri Lanka, especially I think Mr. Tushar as the president of the Government Pharmacists Association. So I wish everyone good luck on this World Pharmacist Day. There were the government pharmacists who are gathered here at this occasion. I'm sorry for not being present there since you are here in Brisbane. So this year's theme, the pharmacy is strengthening the health system. I think especially most of the hospital families who work in government hospitals, I know you here and me, the amount of work you will have and the responsibility you will have on our hand, like to enrich patients' lives. So I think basically what I want to make it very short, I think what we do start is the clinical pharmacy practice in Sri Lanka, where we review the prescriptions and check the appropriateness of the prescribed medication, as well as even at the time of discharge, we can counsel the patients, because what I found within the last 3 days, being into this different sessions in FIP, we have a lot more to do, and most of the countries, even including Nigeria, few countries like that, they are much more ahead in the practice of pharmacy. Every country has their own pharmacists to ensure patients' quality of life and to ensure patients' safety always. So, without taking much time, so thank you, Sharat, President of the Government Pharmacists Association, for inviting PSSL. I think 2 members will come today physically to this occasion there in Sri Lanka. So, I'm on the Sugar Loka Aushadha
ඔස්ට්‍රේලියාවේ බ්‍රිස්බේන් නුවර සිට ප්‍රධාන ලෝක ඖෂධ වේදී සම්මේලනයේ සමග සම්බන්ධ වී සිටින ශ්‍රී ලංකා ඖෂධ විද්‍යා සංගමයේ සභාපති කැලුම් ජයසූරිය මහතාගේ ඔබ ඇමතුමේ වීඩියෝ තාක්ෂණය ඔස්සේ
Now, I cordially invite Vidya Jyoti, Professor Asita De Silva, Senior Professor of Pharmacology, Faculty of Medicine, University of Kelaniya, and former Chairman of the National Medicines Regulatory Authority, Sri Lanka, to deliver the keynote speech. Over to you, sir.
I shared some slides. You have them. Getting that organized. Until then, thank you very much. Good afternoon, ladies and gentlemen. President and the Council of the Sri Lanka Association of Pharmacists, Government Pharmacists, Dr. Vajira Visanayaka, Chief Guest, Director of the National Hospital, ladies and gentlemen. Thank you very much for inviting me this afternoon to give a keynote, but I thought I'd just share some thoughts I have, not so much on pharmacy, but on fundamental responsibility that we have, both as medical doctors that we are, clinicians, as well as pharmacists, that you are, in caring for our patients. And as you heard, I'm a senior professor in the Faculty of Medicine at the University of Kelaniya in Ragama, and I was the former chairman of the National Medicines Regulatory Authority, underlying the word former. And it's a great pleasure to be here and see some of the people I have interacted very closely with. My thought was I will take you some data related to patient issues that we have to probably understand the scale of the challenge that we face on a day-to-day basis especially these days with lots of other challenges that have been imposed on us because of COVID, because of the economic situation, whatever reason, in terms of availability and access to medicines, because a fundamental principle that underpins universal health coverage, one of the fundamental principles that underpins universal health coverage is access to medicine. It's a very, very sacred phenomenon. Let's see if it works. Right, what I'm trying to show you here is work done by Salim Yusuf and his group in McMaster University. They did what was called the five-continent trial to map risk and incidence of cardiovascular disease. What you're seeing here is, so unfortunately, I say, take it up. This is a classification of countries by economic status: high income, middle income, and low income. Blue means urban areas and red rural. In these regions, and they assess cardiovascular risk by a score called INTERHEART score, and that is a very accepted, validated risk assessment score for heart disease. And they showed, back in 2016, in the 5 continents across the world, studying thousands of patients, that the incidence or the prevalence of risk for heart disease is highest in high-income countries and lowest in low-income countries. And there's not much difference between rural and urban populations in any of these regions. But what is important is, what is striking is, although they have the highest risk, and we, as low-income countries, or low-income countries have the lowest risk, we have the highest incidence of disease. If you look at cardiovascular disease here, given myocardial infarction, stroke, heart failure, and so on, we have the yellow bars. The low-income countries have the highest incidence. The lowest is in high-income countries. And in turn, if you look at mortality, death due to heart disease, it's highest in low-income countries and lowest in high-income countries, and without much of a divide between rural and urban. In some areas, rural populations suffer more than urban populations in middle and low-income countries. So in summary, these slides show you, it's a groundbreaking study, a series of studies that showed that high-income countries have very high risk, but the lowest problem associated with myocardial infarction and death, which indicates that we have some challenge in terms of risk mitigation. Our risk mitigation strategies for patients is not up to what it should be. Now, how is that possible? Well, some of my colleagues whom I work at Duke and US have done this very elegant work in the Duke and US, headed by Duke and Institute in Singapore, headed by Tazeen Jaffa and her colleagues, showed that when populations, I hope you can see this, are exposed to long-term deprivation, like in low-income countries, for example, high maternal mortality, low birth weight, malnutrition, and so on, it creates an epigenetic transformation of the DNA that ultimately results in a phenotype, the establishment of a person who has higher risk of suffering from myocardial infarction or non-communicable diseases. When for generations, for years and years, we're deprived as low-income countries. In the low-income countries, I think we end up with a phenotype that has a higher risk of developing these problems. And when that phenotype, that individual or group of individuals exposed to weight gain, raised blood pressure, poor diet, lack of exercise, smoking, and all the bad habits, as we call them, we ultimately have early onset cardiovascular disease and death. And this is true. If you look at data that we have from large number of studies done in South Asia, our children, on average, at the beginning, have more hypertension, more metabolic risk than our counterparts in the Western world. It's the same with diabetes, insulin resistance, early onset end organ damage, and so on. So this whole cycle of deprivation resulting in creation of a phenotype through epigenetic transformation, that's serious about that, gives us all these risks. And we, and therefore, have the highest incidence of problems in terms of cardiovascular disease, with the lowest level of, or the poorest level of risk mitigation. And that's a sad situation to be in. And if I can digress for a minute and show you some survival population data, what I'm showing you here is given to me by one of my colleagues, former colleagues at the University of Oxford, where they mapped through census data 200 years of survival in the United Kingdom. So here on this axis is age, and the other axis here is the percentage surviving. So if you look at data from 1860, you'll see that at the top here, about 30% of children in the United Kingdom, this data is from the United Kingdom, 30% of children in the United Kingdom were dead when they were 5 years old. That's terrible. And very few people lived into their 40s and 50s in 1860. Even Queen Victoria didn't live that long. And hardly anyone went to 70. This is UK in 1860. 50 years later, it changed a little bit, where the curve shifted upwards and to the right in 1910, where less children died and they were fine. More people lived into middle age, and a few went beyond 70. Over the next 50 years, up to 1960, a real transformation happened, where very few children were dead when they were 5 years old. Lots of people were living into their 40s and 50s and 60s, and some were going into their 80s. And then in the next 50 years, in 2010, well, this curve cannot go higher anymore. It's at 100%. Infant mortality, child mortality was almost unheard of. And a lot of people are living into their 80s, 90s, as you can see from this graph. This is in 50-year blocks. This is real data from the census statistics in the United Kingdom. And they attribute this increase in life expectancy, greater survival, to a number of reasons. One is cessation of smoking, better medicines, access to better medicines, vaccinations, and good sanitation. Now, there's a dichotomy here. There's another situation. If you look at what happens in terms of income deprivation. This is information from one of the people who have influenced me in recent times, Sir Michael Mormont, who works at the University College London. His work is about income deprivation and health, access to health, social determinants of health. His work is dedicated to this, and what he's trying to show you here is what you have on the x-axis is age, and on the y, I hope you can see that, yeah, survival. And if you take the two areas, gray and green, it shows life expectancy and disability-free life expectancy by birth, classified by income deprivation. So if you look at the first group of dots here, each dot representing a small part of England, a council or whatever, small part of England, each dot. You can see that so the most affluent, the richest people are there, and the least affluent, the poorest are to the left. So those near the top have a lower life expectancy than those at the top. So richer people live longer. Those near the bottom have a lower life expectancy than those in the middle, indicating there's a gradient that determines life expectancy. If you look at disability-free life expectancy, which is the green section, again, same areas, communities classified by level of income, you will see that if you take those in the middle here, not extremely deprived, but somewhere in the middle, they have 8 years of lower life expectancy and 8 years of lower disability-free, or that means healthy life, than those who are rich. Which means early onset stroke, Parkinson's disease, poor grip strength, falls, and so on. So health is determined by income. Sadly, it's a gradient. A lot of people believe that it's restricted to the poor. That the poorer people have poorer health. It's because they're poor. That's not true. Because it's a gradient. We are somewhere along this gradient. There will be somebody above or somebody below us. And that determines the level of health, between free life expectancy as well as life expectancy that we can expect to have. And this is what he calls the social determinants of health, and his book called Health Gap. I recommend that everyone in healthcare should read that. Now, this is not unique to England. He has shown that in the United States, in this big state, in a big city called Baltimore, in an area that has the average, the monthly household income of $92,000 US, the life expectancy is 82. Not far away from there, in a deprived community called Upton Druid, where the annual income, household income is $18,000 US, not 92. Life expectancy is 62. It's 20 years less in the same city, determined by the level of income you have. We don't have data like this in Sri Lanka, but I'm sure it's not any different to this. And that's the sad challenge that we deal with on a regular basis. When we do good epidemiology, you come across this. This again is from the Nuffield group in Oxford, which has shown something very interesting. Again, this age is going up to about 90 years. Black dots indicate affluence, richer people. The red ones are those who are underprivileged. If you look at the two curves, you can see that when we are young, we have less problems, better quality of life. And as we age, the problems increase in terms of mortality and morbidity. But those in the poorer areas, that's given in red, have the onset of these problems early. In other words, 60 to 64-year-olds in England have the same level of bad health that 90-year-olds, the richest 90-year-olds have. So what a rich person has in terms of ill health at 90 years, a poorer person will have at 60. I hope I have made my point. The point being, our social level, our level of income, level of deprivation, which, at least in England, which area of country you come from, will determine your overall health. And that's a sad truth. We did a study recently, a large randomized controlled trial on hypertension. Hypertension is the biggest killer in the world. And rural communities, as you saw in the first 3 slides I showed you, are very, very badly affected. We usually thought that there's a big divide between rural and urban. That's not the case. Rural folk are as badly affected as urban people with non-communicable diseases. And in this study, which we published in 2020 in the New England Journal of Medicine, which we did with Bangladesh and Pakistan, we looked at level of hypertension control and improving hypertension control in very rural communities involving 2,500 plus patients with high blood pressure. And in our community, it was in rural Puntland. Some areas as close to Wilpot West you can get. Very, very rural people, extremely poor. They live off the land. There's no public holiday, there's no Saturday, Sunday. Every day they work on the fields. Now, we had a cluster randomized approach to this, where a multi-component intervention, which had advice, lots of other things, as well as advice to take medicines, compliance to medication, and regular screening for blood pressure, was delivered through public health midwives. The trial was designed so that we use existing healthcare systems to deliver this intervention. And after 3 years, we showed that those who received this message and regular review and screening and advice to take their hypertensive medication, at the end of 3 years of the study, of follow-up, they did much better. The blood pressure was much better controlled. Because as I said, hypertension is the biggest killer in the world, and uncontrolled high blood pressure is a serious public health problem. And during this study, this is what I'm trying to show you here, this is baseline information. This is baseline information from the 3 countries, Bangladesh, Pakistan, Sri Lanka. Forget those 2, look at this. In Sri Lanka, rural community input rate. We had almost at baseline, at the beginning, no intervention, about 40% had diabetes, had about 75% had CKD, chronic kidney disease, defined as less than 60 eGFR, milliliters per minute, or IUGFR of more than 30. Very significant renal disease. 75%, about 50% of them didn't even know that they had. And 86% had at least 2 comorbidities, heart disease and kidney disease, or diabetes and kidney disease and diabetes and heart disease. This is a very rural, very poor community. And more than 60% did not have their blood pressure control. They were hypertensive, some of them on treatment, and only about 30% had blood pressure control in a very rural population. There are many reasons for this, as we know, because there are various barriers that patients experience to achieve or get appropriate care, or the best available care. If you look at the patient level, poor access to health care, poor knowledge, poor insight about diseases, as well as poor access to medicines, which is the cost of my talk. Poor access to medicine. Access can be for many reasons, shortages, price, whatever. Reduce access to medicine. At the provider level, lack of knowledge, clinical inertia on the part of physicians like me to increase dosages or add other medicines. Time constraints that we have in busy practices, poor communication. As you know, doctors in this country, even in the private sector, are notoriously bad in terms of communicating with patients. We hear this complaint all the time. And I think that applies to you as well. If you're dispensing in a hospital, you see a lot of patients who come with a white envelope with some medicines inside. They have not been advised properly, there's nothing much written on it. These are bad practices at the provider level and at health systems level, where we don't have good screening facilities, like in Putin. Obviously, they're not screening for anything appropriately, except for maternal and childhood diseases, because midwives do that. I'm talking about NCDs here. A number of other reasons: poor availability of medicines, poor screening. Patients have problems accessing appropriate care. And on top of that, you add the cost of medicines, especially at a time when there is low availability of medicines in the government hospitals. Many people are being sent to a private clinics, private pharmacies to acquire their medicines. That's called access to medicines. And if you look at prices, I'm not criticizing it, I'm just giving you facts. For some very commonly used medicines for a person, let's say, who has diabetes and hypertension, don't forget 25% of our population has high blood pressure and about 16% has diabetes. And these people will be forced, most of them, to go to the private sector, private pharmacies to get their medicines. I'm not blaming them, it's telling you facts, as I said. In 2019-20, these are the price per unit, same doses. I'm talking about, I'm looking at the same brands here. And in 2022, these are the prices, for whatever reason. And as a result, this commonly used prescription, which would have cost a patient 3,118 rupees per month, would now cost him or her 7,000 plus rupees, more than double. That is a problem that we encounter today on a day-to-day basis in terms of accessing medicines. So, in addition to this problem, take the overall healthcare problem that I mentioned to you earlier. Higher risk, poor screening, hugely prevalent problems of kidney disease, hypertension, diabetes, heart disease, and so on. I think we are facing a catastrophic situation. And I said, as healthcare providers, responsible healthcare providers, we've got to be able to do something within our powers, within our knowledge, within our capacities to address the situation. If we don't, there will be catastrophic consequences where the poorest, the most deprived, because as I showed you that gradient, the most deprived will be worse off than the others. Will we see more, because of this problem, will we see more amputations due to poor diabetes management? Will we see more heart attacks, more strokes? Yeah, you can bet your bottom dollar you'll see that. Because there's a problem. And I hope your association will do these discussions, will come together and work with the medical professionals across the healthcare system in this country, systems in this country, to address these very, very important issues. And that's exactly what I want to point out today, that we have a serious problem. I don't have a solution right now, but at least if we understand there's a problem, maybe we can find a solution. Thank you very much.
Sir, can you please remain on the stage, please? We are honored to have you for this occasion, sir. To represent that, I would like to invite Mr. R.M.G.M. Ratnayaka, Secretary of Society of Government Pharmacists, for give token of appreciation.
Good evening, dear gentlemen, ladies and gentlemen. I stand here today as a General Secretary to the Society of Government Pharmacists. I would like to thanks to the Professor Asita D. Silva. Sir, you have delivered us a very special speech, and I would like to appreciate your dedication, and you have devoted your time, and actually your participation for this occasion is highly appreciated. So thank you very much, sir. Thank you very much.
ස්තුතියි. තවත් සුවිශේෂී මොහොතක් ශ්‍රී ලංකීය ඖෂධ වේදී වර්ෂ කතාව. එදා වෙලා තුල කාලය ගත විට විවිධ අර්බුදයන්ට විවිධ ගැටලු වලට මුහුණ දෙමින් අපේ රටේ අහිංසක ජනතාව විවිධ අර්බුදයන්ට මුහුණ දෙන මොහොතක සෞඛ්‍ය සේවාව යම්කිසි අර්බුදකාරී තත්ත්වයක තිබෙන මොහොතක ඒ පැන නැගිට සෑම ගැටලුවක් निराකරණය කරගැනීමෙන් ඖෂධ හිගයකින් තොරව මඩා කළමනාකාරීත්වයකින් යුතුව රෝගී දරන්නට ලබා දීම සඳහා රජයේ ඖෂධ වේදික විශේෂින්ම විශාල පරිශ්‍රමයක් ලක්වා. අපි මේ කතා කරන මොහොතේ බොහෝ විට සැපයුම් දාමේ කටයුතු කරන අපේ සහෝදර ඖෂධ වේදික වේදිනියන් තමන්ගේ ජංගම දුරකථනය දෙසමනේ රඳවගෙන සමහර විට රෝගී සත්කාර සඳහා අවශ්‍ය වෙන අත්‍යවශ්‍ය ඖෂධයක් හොයනවා වෙන්නට පුළුවන්. ඉතින් මේ සා දීර්ඝ කාලයක් තිස්සේ සෞඛ්‍ය සේවාවේ බලගැන්වීම සඳහා ඖෂධ වේදික විසින් සිදු කරන වාහකේ කාර්යභාරය ඉදිරියටත් ඒ ආකාරයටම පවත්වා ගන්න. අපෙන් ඉදිරියේදී නව පත්වීම් ලබාගෙන සේවාවට එකතු වෙන ඖෂධ වේදිනියන්ට ඒ වංශ කතාව පිළිබඳව ඒ කාර්යභාරය පිළිබඳව මනා දැනුමක් තිබිය යුතුයි. ජේෂ්ඨත්වය කරපින්නාගෙන ඒ වෘත්තියේ සාර්ථකත්වය ජේෂ්ඨත්වයෙන් ඔවුන්ගේ දෑතට පත්විය යුතුයි. ඉතින් ශ්‍රී ලාංකීය සෞඛ්‍ය සේවාවේ යම්කිසි හැරවුමක් බවට පත් වුණා. ඖෂධ වේදී වෘත්තියේ උපාධිධාරී පාඨමාලාව රජයේ විශ්වවිද්‍යාල පද්ධතිය තුල ආරම්භ වීම මේ රටේ සෞඛ්‍ය සේවාවේ උන්නතිය සඳහා මහඟු කාර්යයක්, මහඟු ආරක්ෂාවක් කියලා අප විශේෂයෙන්ම සඳහන් කළ යුතුයි. ඉතින් මෙදා තුල සේවාවට එකතු වන මේ ඖෂධ වේදී සිය ජේෂ්ඨයන්ගේ මඟ පෙන්වීම, තමන්ගේ සෞඛ්‍ය සේවාව පිළිබඳ තමන්ගේ පුද්ගලික කියවීම, මහ ජනතාව පිළිබඳ ඔවුන්ගේ ඇති ආකල්ප මේ සියල්ලම එකතු කරගැනීමෙන් නිර්මාණය වෙන ඒ නව ඖෂධවේදියා සෞඛ්‍ය සේවාවේ උන්නතිය උදෙසා සිදු කරන කාර්යභාරය අප විශේෂයෙන් වගය කළ යුතුයි. ඉතින් මේ මොහොතේ අප 2023 ලෝක ඖෂධවේදී සැමරුම සිදු කරන මොහොතේ අප සූදානම් වන්නේ මේ වන විට විශ්වවිද්‍යාල පද්ධතියෙන් සහ ඖෂධවේදී විද්‍යාලයෙන් සිය පුහුණුව අවසන් කර ඉතා සාර්ථක අවසන් කරමින් දැනුම කුසලතා කල්පයේ සෑම දෙයකින්ම සන්නද්ධ වෙමින් සුවිශේෂී හැකියාවන් පෙන්වූ ශ්‍රී ලංකීය අනාගත ඖෂධවේදී වෘත්තිය අනාගතය ලබා ගැනීමට බලාපොරොත්තු වන ඔබ වෙනුවෙන් රජ ඖෂධවේදීගේ සංගමයෙන් පිරිනමන විශේෂ සම්මාන ප්‍රදානය සඳහායි අප මේ සූදානම් වන්නේ.
மீண்டும் உங்களுடன் இணைவதில் மகிழ்ச்சி அடைகின்றேன். கல்விச்சாலைகளில் இருந்து கற்றுக்கொண்ட கற்றறிவும் மூத்தவரிடமிருந்து பெற்றுக்கொண்ட அனுபவ கல்வியும் தான் எம்மை செம்மைப்படுத்தியது. எமது உன்னதமான சேவைக்கு வித்திட்ட மூத்தவர் வழிகாட்டலில் நடப்பதால் தான் நாம் தடக்கி விழாமல் நடைபெறுகின்றோம். என் அன்பான இளைய சகோதர சகோதரிகளே, எமது சேவையை வளப்படுத்த, எமது சேவையை வலுப்படுத்த உங்களின் சேவை எங்களுக்கு தேவை. இது உங்களின் பொறுப்பும் கூட. ஆதலால் தான் கல்வியியல் கல்லூரிகளில் பல்கலைக்கழகங்களில் முன்மாதிரியாக திகழ்ந்த உங்களில் சிலரை கௌரவிக்க தீர்மானித்து வழிப்படுத்தி இருக்கின்றோம்.
සම්මාන ප්‍රදානෝත් සඳහා ගෞරවයෙන් ආරාධනා කරනවා විද්‍යාජෝති මහාචාර්ය අසිතද සිල්වා මහතාට අනාගත ඖෂධවේදී වෘත්තිය බාර ගැනීමට සිටින බෞද්ධ රජ ඖෂධවේදීගේ සංගමයෙන් පිරිනමන ඒ සම්මාන ප්‍රදානය සඳහා
You are our future. Thank you for being the pillars of strength of our field. For that, I would like to invite these honored guests to accept the token of appreciation. Miss G.D.A.I. Priyadarshani, Most Outstanding Student of Internal Pharmacy 2019-2021 batch, School of Pharmacy, Faculty of Medicine, University of Colombo. Mrs. S.C. Ilangamge, Most Outstanding Student of 35th Intake, Department of Pharmacy, Faculty of Allied Health Sciences, General Sir John Kotalawala Defence University. Miss W.G.C.S. Chaisiri, Most Outstanding Student of 2016-2017 batch, Department of Pharmacy, Faculty of Allied Health Sciences, University of Peradeniya. Mr. R.M. Kisara Sampath, Most Outstanding Student of 2020 Convocation, Department of Pharmacy, Faculty of Health Sciences, Open University of Sri Lanka.
සම්මාන ප්‍රදානය සඳහා අපගේ ආරාධනය දෙන්න පැමිණි විද්‍යාජෝති මහාචාර්ය අසිතද සිල්වා මහතාට වෙන්නේ ස්තුතිවන්ත වෙනවා. ඊළඟට සම්මාන ප්‍රදානය සඳහා ගෞරවනීය ආරාධනය මහාචාර්ය වදිර දිසානායක මහතාට එතුමන් වේදිකා මස්තකයට කැටු වෙන්නට රජ ඖෂධවේදීගේ සංගමයේ ගරු සභාපති තුෂාර රණදේව මහතාට ආරාධනා කරනවා.
Mr. W.M.D.N. Karaka, Most Outstanding Student of 2022 and 2023 batch, BSc Special Pharmacy Program, Faculty of Science, University of Colombo. Miss Kaushika Kulasingham, Most Outstanding Student of 12th batch, Department of Pharmacy, Faculty of Allied Health Sciences, University of Jaffna. Mrs. N.K.P.G. Chandrasena, Most Outstanding Student of 2016 and 2017 batch, Department of Pharmacy, Faculty of Allied Health Sciences, University of Ruhuna. Miss G.H. Himanti Ragadayas, Most Outstanding Student of 2017-2018 batch, Department of Pharmacy, Faculty of Allied Health Sciences, University of Sri Jayawardhanapura. Thank you very much, sir. Without you, we could not have done this much as a success event. Our sponsors, Cellogen Pharmaceuticals, Dear the Pharmaceuticals, Kelun Life Science Private Limited. Now you can join with their presentations.
ශ්‍රී ලංකාව සංවර්ධනය දෙමින් පවතින රටක්. නමුත් ආර්ථික අර්බුදය සමග එම සංවර්ධනය අඩාල ලබනවා. ශ්‍රී ලංකාවට අද වන විට පිටරටින් ඖෂධ ගෙන්වීම, උපකරණ ගෙන්වීම ප්‍රශ්නයක් බවට පත් වෙලා තියෙනවා. මේ පිළිබඳව අපි පොඩි අධ්‍යයනයක් කරලා අපේ නිරීක්ෂණය වුණා රෝහල් වල වසර අවසානයේ ලොකු ප්‍රමාණයක් සර්ජිකල් ඉන්ස්ට්‍රුමන්ට්ස් යකඩ බරට ටෙන්ඩර් කඩවලා විකුණන බව. අපිට පුළුවන් නම් මේ අයින් කරන ලද අපද්‍රව්‍ය හැටියට අයින් කරන ලද සර්ජිකල් ඉන්ස්ට්‍රුමන්ට්ස් නැවත භාවිතයට ගැනීමට අප හිතනවා ආයතනයක් හැටියට එය ලංකාවේ සංවර්ධනය සහ ලංකාවේ ආර්ථිකයට වන්න පුළුවන් ලොකු සහයෝගයක් තියෙනවා. අපි මේ ව්‍යාපෘතිය පයිලට් ප්‍රොජෙක්ට් එකක් හැටියට කරාපිටිය ශික්ෂණ රෝහල, තේරාදෙණිය ශික්ෂණ රෝහල සහ මහනුවර ජාතික රෝහලේ අපි දැනට සිදු කරන අවසානයේ මේක ප්‍රොජෙක්ට් එක කරාපිටිය රෝහලේ කරනකොට ඉන්ස්ට්‍රුමන්ට්ස් 412ක් අතුරින් 154ක් එනම් ඉන්ස්ට්‍රුමන්ට්ස් 220ක් අපිට සාර්ථකව නව උපකරණ හැටියට නව ඉන්ස්ට්‍රුමන්ට්ස් හැටියට නැවත භාවිතයට යොදා ගන්න හැදුවා. තේරාදෙණිය රෝහලේ ඉන්ස්ට්‍රුමන්ට්ස් 260කින් ඉන්ස්ට්‍රුමන්ට්ස් 115ක ජාතික රෝහලේ මහනුවර ඉන්ස්ට්‍රුමන්ට්ස් 196කින් 148 එනම් ඉන්ස්ට්‍රුමන්ට්ස් 95ක් අපිට නැවත භාවිතයට යොදා ගන්න පුළුවන්. ඉන්ස්ට්‍රුමන්ට් එක රිපෙයාර් කරනකොට රිපෙයාර් ක්වොලිටි එක තමයි ගොඩක් කන්සර්න් වෙන්නේ. සම්පූර්ණ සැලකෙන්නේ වින්ඩෝ වල රිපෙයාර් ක්වොලිටි එක ගැන. දැන් අපි බැලුවොත් මේ ඉන්ස්ට්‍රුමන්ට් එක මේක ගෝල්ඩ් මෙඩල් ඉන්ස්ට්‍රුමන්ට් එකක්. මේක ටිප් එක එනම් තුඩ ඉකෝ ටන්ස්ටන් කාබයිඩ් ඉකෝ ඩයමන්ඩ් ටස් ලංකාවේ මේක රිපෙයාර් කරන්න කිසි හැකියාවක් නැහැ. නමුත් ඔබ පුදුම වෙයි මේක පටපාරක් රිපෙයාර් කරන්න පුළුවන් ඉන්ස්ට්‍රුමන්ට් එකක් කියලා. සාමාන්‍යයෙන් එදරක වගේ සර්ජිකල් ඉන්ස්ට්‍රුමන්ට් එකක් අපිට සලකන්න බෑ. මොකද මේ ඉන්ස්ට්‍රුමන්ට් එක සාමාන්‍ය කතරකට වඩා බොහෝම මිල අධිකයි. මේ ඉන්ස්ට්‍රුමන්ට් එකට සාමාන්‍ය කතරකට දෙන සත්කාරය දෙන්න බෑ. මේක හරි විදිහට රැපියාල් කරොත් අත්තර පාරක් යූස් කරාට මේක වැරදියට එකපාරක් රැපියාල් කරොත් ඇති මේක ඩිස්කාඩ් කරන්න. එතකොට අපි බලමු මේ ඉන්ස්ට්‍රුමන්ට් එක අපි සාමාන්‍යයෙන් රුපියල් 95,000ක් වටිනා කියන ඉන්ස්ට්‍රුමන්ට් එකක් මේක රැපියාල් කරන්න අලුතෙන්ම ගන්න. එහෙනම් රුපියල් 95,000 රුපියල් සාමාන්‍ය 100ට 10ක් 20ක් යන වගේ ගාන තමයි රුපියල් කොස්ට් එක හැදෙන්නේ. රුපියල් බියර් හැදෙන්න ඔය කට්ටියට වැය වෙන්නේ. ඒක අලුතෙන් ඉන්ස්ට්‍රුමන්ට් එකක් ගන්නවා නම් රුපියල් 95,000 රැපියාල් කරනවා නම් නැවත බ්‍රෑන්ඩ් නිව් කන්ඩිෂන් එක ගේන්න අප ආයතනයට යන්නේ සාමාන්‍ය මුලින් ගන්න ඉන්ස්ට්‍රුමන්ට් එක ඔරිජිනල් වැලියු එකෙන් 10ක් 20ක් අතර වගේ සුළු මුදලක්. ඒ වුණාට ක්වොලිටි වෙනසක් නැහැ. මේක බ්‍රෑන්ඩ් නිව් භාවිත නොකරන ලද ඉන්ස්ට්‍රුමන්ට් එකක් වේගම අපිට අරන් යනවා. මේ රැපියා ප්‍රොජෙක්ට් එකට අපි ඔය කට්ටියගේ දායකත්වය අපේක්ෂා කරනවා. මේකට තියෙන හරි සුදුයක්. ප්‍රොජෙක්ට් ඉන්ස්ට්‍රුමන්ට්ස් කන්ටෙන්ට් කරන්න තියෙන බොක්ස් එක කන්ටෙන්ට් කරන්න එපා. ආයෙත් අපිට කෝල් එකක් දෙන්න. අපේ නම්බර්ස් මේ ස්ක්‍රීන් එකේ ඔන් ඩිස්ප්ලේ කරන්න. රිපෙයාර් අපි ඒ ඉන්ස්ට්‍රුමන්ට්ස් තෝරලා ගන්න මොනවද රිපෙයාර් කරන්න පුළුවන් මොනවද ඔයාලා ඩිස්කාඩ් කරන්න ඔයාලා ඩිස්කාඩ් කරන්න වෙන්නේ මොනවද කියලා. අපි රිපෙයාර් කරන්න පුළුවන් ඉන්ස්ට්‍රුමන්ට් එක නැවත බ්‍රෑන්ඩ් නිව් කන්ඩිෂන් එක දින 45ක් ඇතුළත අපි ලබා දෙන්නම්. මේ සඳහා මිනිස්ට්‍රි ඔෆ් හෙල්ත් සෞඛ්‍ය අමාත්‍යාංශය තියෙනවා. ඔයාලට මේ සඳහා යන ප්‍රොසීඩියර් එක අපි ඇවිල්ලා හදලා දෙන්න. ඔයාලට දින 45කින් කන්ටෙන්ට් කරන්න පුළුවන් not functioning instruments නැවත fully functioning instrument එකකට අපි හදලා දෙනවා. බොහොම ස්තුතියි.
Now, I would like to call upon Professor Vajira Disanayaka, the chief guest of this ceremony and President of Sri Lanka Medical Council and Dean, Faculty of Medicine, University of Colombo, to the stage to enlighten the gathering. Over to you, sir.
Good afternoon, everyone. President, Secretary, Council members, members of the Government Pharmacist Association, fellow pharmacists, distinguished invitees, ladies and gentlemen. I am pleased to have been invited to be your chief guest this afternoon. It is indeed a pleasure for me to be here today. I thought I will talk to you a little bit about what the Sri Lanka Medical Council is doing in the space of regulation of the practice of pharmacists, as well as the other association that I give leadership to, or the other organization that I give leadership to. You would have heard of the Ceylon Medical College Council, because I also, by virtue of my position in the Faculty of Medicine, I also function as the registrar of the Ceylon Medical College Council. Both these organizations are very important for your education and practice. The Ceylon Medical College Council, as you know, regulates the education of not only the pharmacists, but also all other categories of, if I were to use the word, non-medical staff, except the nurses. Whereas the Sri Lanka Medical Council
regulates the practice of all the non-medical staff except nurses and of course the doctors and the dentists. Now, you may wonder, what are we doing? What are we doing in these organizations? And how does that impact your education and practice? Now, let me start with the Ceylon Medical College Council. I was appointed the registrar of the Ceylon Medical College Council last year, around early last year, around April, May. And it has been about 1.5 years now. What I found when I took over was that the educational sector in the field of not only pharmacy, but all other non-medical categories of staff that we regulate has not been systematically looked at by the regulator, the Ceylon Medical College Council. So I set up subject committees, not only in pharmacy, but all other categories of non-medical staff that we regulate. So we set up subject committees comprising of principals of schools of pharmacy, the heads of departments of pharmacy in medical schools, medical faculties, and so on. Then representation from your professional association, the Society of Pharmacists, and some senior pharmacy professionals. And that committee has been looking at and working on giving me and the council a concept paper which looks at all aspects of the education of pharmacists. And I'm looking forward to receiving that concept paper probably in a few months' time, so that we can then look at the overall concept of how we recognize the various training programs in the field of pharmacy, what designations we give them. Is everybody going to be a pharmacist, or are there other types of pharmacy practitioners that we are also going to recognize, and so on, so that we would be able to provide a comprehensive service to our profession, our people of the country. It is so very important for us to do that, because we haven't at regulatory level looked at this from the inception of the Ceylon Medical College Council way back in 1926. We have never done this, just been looking at and doing various patchwork, as it were. Now, the reason why that is so very important would have dawned on you far before today's meeting. We've got, if you look at now, the education sector of pharmacy in this country, the internal pharmacists coming from the pharmacy schools. We have the external pharmacists who are training out there, and we have no clue as to what training they go through. But we know that the training that they go through is very poor, because the pass rate at the external pharmacy exam is probably one of the lowest pass rates in any public exam in this country. So we cannot continue this trend, because eventually, as you know, when we go to a pharmacy in a faraway place, it is one of those apprentice pharmacists either aspiring to be an external pharmacist or aspiring to sit the external pharmacy exam, or someone who has absolutely no pharmacy training, who is dishing out the prescriptions that the doctors have provided their patients. So this practice that has been going on for so many years, so many decades, cannot go on in the modern world. Thirdly, we've got the, so if I were to add a few things for the external pharmacy, we need to then bring those external pharmacists into some structured training program. What about the trainers, the master pharmacists? They also have to undergo some structured training program to be eligible to become master pharmacists. And these are the discussions that we are having, not only at the Ceylon Medical College Council, but at the level of the Ministry of Health, as well as the level of the National Medicines Research Regulatory Council, NMRA agency, National Medicines Regulatory Agency, as well as with your professional colleges and, of course, the departments and the schools. And you too, the association has the opportunity to make representations to us, and I plan to convene a stakeholder meeting very soon about it, and I welcome all your suggestions. Thirdly, we've got the universities producing graduates of various levels. We have the B.Pharms, we have the BSc Pharmacy programs, and so on. We need to also look at taking these to a higher level, and we are also in the Faculty of Medicine, Colombo, looking at the possibility of introducing a B.Pharm program, and I'm committed to ensuring that that would happen sometime. And of course, we need to go into higher level programs at master's and doctoral level to enable all of you to become equal practitioners along the side of the doctors. I'm someone who is committed to equal rights to all professionals. We need to recognize everybody's contribution. We are all a part of a multidisciplinary team. We need to cut across, narrow boundaries of whatever form, and ensure that every sector in the healthcare profession develop to the highest level possible. I'm also committed to bringing in the support of international organizations. I also head another organization called the Commonwealth Health Professions and Partners Alliance. And amongst the Commonwealth Health Professionals and Partners Alliance is an organization called the Commonwealth Pharmacists Association. And the president of that sits in my council. And we talk very often on how we can work together. And currently, to the work that we are doing in the Ceylon Medical College Council, we have the inputs coming in from the Commonwealth Pharmacist Association, as well as another organization which you may be familiar with, CASPER, which is an organization based out of Australia, which has been working with the pharmacy education in the country in all the medical schools, as it was, or the allied health faculties working with the departments of pharmacy. And I've been briefed on the work that they have done. I've been briefed on the quality improvements that they have brought to the pharmacy practice in the country. And I'm very pleased to see all those developments. And I might say I'm committed to ensuring that those practices become widespread and eventually benefit the segments of society like the one that Professor Asita Silva mentioned, who need the most help in our country. So, in the future, in the coming years, I would like to invite the association as well as everyone else in your profession to engage us so that we would bring the standard of pharmacy education in the country to the highest level on par with the international standard, as well as the regulation of pharmacy education in the country to the highest level on par with the international standard. And that's a commitment that I'm giving all of you. And I need your help. It's not something that I can do alone. I need all of you to provide that help to me. Moving on to pharmacy practice, which is in the realm of the Sri Lanka Medical Council, of which I'm the president. Now, when I took over president of the Sri Lanka Medical Council about 3 years ago, to my dismay, I found that the non-medical categories of staff or practitioners have never been registered or renewed their registration or re-registered, or whatever the name you call it, or requested to renew their registration. And so therefore, we had no idea of how many registered pharmacists were in this country, although we had a number saying this many people we had registered. So prior to doing a registration, we thought that we will call for expressions of interest or ideas from not only pharmacy professionals, but also all categories of non-medical practitioners. We put a newspaper advertisement on that, but we hardly got any response, worthwhile response. Then we had a few discussions, and thereafter we thought, okay, let's just go and renew the registration of all the pharmacists and other non-medical categories of practitioners, like we do for the doctors. And lo and behold, we started that process more than a year ago, I should say 2 years ago, but initially the response was very poor in terms of those who wanted to renew their registration. Eventually we extended it many a time, and following the final extension, which ended I think on 31st March of this year, we had 5,630 odd pharmacists registering. And what is important about that is, after the doctors and the nurses and the midwives, the fourth largest category of practitioners registered in this country are the pharmacists. So we at least now know that there are roughly more than 5,600 registered pharmacists in the country, but we really don't know how many of them have not how many who had originally got the registration, who are practicing out there, still have not renewed their registration. So it is important for all of you to reach out to your colleagues who may have not renewed their registration and tell them, renew your registration, because legally it is a criminal offense to practice without a valid registration, and we will be issuing those certificates of renewal of registration with a validity date of 1st of October this year, starting very soon. So those of you who have renewed your registration would get a new certificate, which is QR code enabled to verify that this is an authentic registration from the Sri Lanka Medical Council very soon. So that is the first step. But with that also comes accountability. And we need to work with all of you, all of your organizations, associations, societies, professional associations, and so on, to develop the code of practice and publish that as the standard that we expect from practitioners in this country. Because as you know, we very often see advertisements in the newspaper. What are those advertisements? Advertisements by people apologizing to the public of Sri Lanka for selling unauthorized pharmaceuticals, or all kinds of professional digressions, as it were. But we have never taken any action against them, and there is a professional code of conduct, or a professional in our in the Sri Lanka Medical Council, there are regulations for receiving complaints, inquiring into those complaints, and taking action against those practitioners who have not engaged in proper practice, which is up to the professional standards. But we cannot hold people accountable first without knowing how many of them are out there, and having got them to renew and got them to have valid registration. So we have done that now. That's the legal mandate that the SLMC has. The next is for us to develop those practice guidelines. You can go to the slmc.gov.lk website and take a look at the guidelines for doctors, similar guidelines or better guidelines in collaboration with all your international partners and so on, so that we can now work on educating the practitioners out there on the high standards that they should aspire to. And also, when someone has not lived up to those expectations, to take action with the aim of not punishing people but correcting people, so that they live up to a certain standard that we expect them to live up to. After all, we have so many people leaving this country to other parts of the world, and when they go there, they subscribe to a higher level of practice. But because over nearly 100 years of the existence of these regulations in our country, we haven't really defined what the practice standards are and held practitioners accountable. It has become a free-for-all out there, and unfortunately, the media these days is playing it up, and as a result of that, all of us are suffering. The practitioners in the field of medicine, whoever they may be, pharmacists, doctors, nurses, and others, everybody is suffering. So therefore, we need to all work together to improve the standard of practice that we aspire for, and it is so very important. So, heading these two organizations, I'm committed to working with you to improve both education and practice in your profession. And going forward, let's that we take the field of education in pharmacy as well as the field of practice in pharmacy to very high levels. It's a collaborative effort with the regulator, the educational institutions, the professional associations and the trade unions, the Ministry of Health, the MRA, as well as the pharmaceuticals industry, both the manufacturers and the importers. And all of these people have reached out to us to say that we need to take these levels to a higher standard. And I would like to facilitate the discussion among all the stakeholders so that we get to that high pedestal that we all aspire for. So with those words, I hope I have kind of presented to you and articulated to you the work that we are doing in the Ceylon Medical College Council and the Sri Lanka Medical Council. It is a clear direction for the future. I know there has been disappointments with the way the Ceylon Medical College Council worked and the disappointments in the way the Sri Lanka Medical Council worked towards the non-medical professionals. But I can give you an assurance that I would and I'm willing to work with all of you, as I have demonstrated during the past 3 years, to ensure that what we've started is taken to a higher level. And I hope that this invitation today is a starting point in an engagement that I can have with your association, because I think at the end of the day, all of us are working towards a common aim, that is the health of our people. Thank you very much.
Sir, can you please remain on stage? I would like to invite Mr. Tushara Ranadeva, President of Society of Government Pharmacists, for give token of appreciation. Thank you very much, sir. Now you can join with the song dedicated for pharmacists.
Enter the world of pharmacy. It held in world supremacy. The legends left us the legacy. So we are the future to prophecy. It's दुनिया में लोगों का मसीह. उतरने के लिए बेबसी बेबसी. We are the future. Yeah, we are the future. सोच अनाज इस दुनिया में लोगों का नसीब दूर करने के लिए बेबसी बेबसी We are the pharmacists, we are the future. Yeah, 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 we are the future.
We gotta streamline these ideas. We need grammar night.
ස්තුතියි. ඊළඟට 2023 ලෝක ඖෂධ වේදියේ දින ප්‍රධාන සැමරුමෙහි සමාප්තිය සහිතවහන් කරන්නට ප්‍රථමයෙන් ස්තුති කතාව ඉදිරිපත් කිරීමට රජ ඖෂධ වේදිකේ සංගමයේ ගරු ප්‍රධාන ලේකම් රත්නායක මහතාට ගෞරවයෙන් ආරාධනා කරනවා.
நன்றி மறப்பது நன்றன்று. அடுத்து இங்கு அழைக்கவிருப்பது நன்றி உரையினை வழங்குவதற்காக
I cordially invite Mr. R.N.G.M.B. Ratnayaka, Secretary of the Society of Government Pharmacists, to deliver the vote of thanks and to adjourn the ceremony.
සුබ සන්ධ්‍යාවක් සියලුම දෙනාට. අපගේ විශේෂ ආරාධිත මුක්තාවන මහාචාර්ය වදිර දිසානායක මහතුමනි, ඒ වගේම මේ අවස්ථාවට පැමිණි අනෙකුත් ආරාධිත මහත්මයාණනි, රජයේ ඖෂධ සංගමයේ සභාපති තුෂාරමදේව සහෝදරයන්, අනිත් මේ පැමිණි සිටින අපගේ සියලු සහෝදර සහෝදරයන් අවසරයි. විශේෂයෙන් මා මේ අවස්ථාවේ අපගේ ප්‍රධාන ආරාධිත මුක්තා වශයෙන් මේ පැමිණි වජිර දිසානායක මහාචාර්යතුමාට මාගේ ගෞරවනීය ස්තුතිය රජයේ ඖෂධීය සංගමයෙන් වෙනුවෙන් මේ අවස්ථාවේ පිළිගන්නවා. විශේෂයෙන් එතුමා අද දිනේ ඊටාම වැදගත් දේශනයක් කරා. විශේෂයෙන් අපේ এডুকেෂන් ප්‍රැක්ටිස් සහ ඒ අපේ සර්විස් එක අප්ඩේට් කරගන්න ඕනේ කොහොමද කියන ඒ පුළුල් අවබෝධයක් ඇතුව ඒකේ සෞඛ්‍ය සේවාවේ ප්‍රොෆෙෂනල් සහ නන් ප්‍රොෆෙෂනල් කියන දෙගොල්ලන්ම මේ සේවාවේ ඉදිරියට ගෙන ගියොත් තමයි අපිට අවසාන වශයෙන් අපේ රෝගී සත්කාර සේවා සාර්ථක කරගන්න පුළුවන් වෙන්නේ. ඒ පුළුල් දැක්මෙන් යුතුව එතුමාන් ඉතා අගනා දේශනයක් අපහම් මෙතබුවා. මා ඉතාම ගෞරවාන්විතව සිහිපත් කරනවා එතුමනි, ඔබතුමාට බොහොම ස්තුතියි. අද ඔබගේ වටිනා කාලය අප වෙනුවෙන් විඩාවු කරමින් මේ අවස්ථාවට පැමිණීම සම්බන්ධ. ඒ වගේම අපගේ ප්‍රධාන දේශනය මහාචාර්ය අසිත සිල්වා මහත්මයාන් ඒ වගේම අපිට වටිනා දේශනයක් අද ඖෂධ වේදී දිනේ නිමිත්තෙන් ඔබ අපහාමී ලැබුවා. එතුමාට රජයේ ඖෂධ වේදීගේ සංගමයේ වෙනුවෙන් මාගේ ගෞරවනීය ස්තුතිය මේ අවස්ථාවේ පුද කරනවා. ඒ වගේම මේ අවස්ථාවට පැමිණි අපගේ PSSL සංගමේ මහත්මීන් දෙපළට මගේ ගෞරවනීය ස්තුතිය මේ අවස්ථාවේ පුද කරනවා රජයේ ඖෂධ වේදීගේ සංගමයේ වෙනුවෙන්. ඒ වගේම මේ අවස්ථාවට පැමිණි අනෙකුත් වෘත්තීය සමිති නියෝජනය කරමින් මෙහි පැමිණි මහත්මීන් සියලු දෙනාටත් මාගේ ගෞරවනීය ස්තුතිය මේ අවස්ථාවේ පුද කරනවා. ඒ වගේම විශේෂයෙන් සඳහන් කරන්න ඕනේ අද දිනේ මේ වේදිකාවේදී අප අගයීමට ලක් කරා අපගේ අනාගත ඖෂධ වේදී ශිෂ්‍යයෝ. මෙම ශිෂ්‍යයන් තෝරා දීමේදී අපගේ සියලු විශ්වවිද්‍යාලවල අපගේ ඖෂධ වේදී දෙපාර්තමේන්තුවේ ඒ ප්‍රධානී සහ ඒ වගේම අපගේ ඖෂධ වේදී පාසල්වල ප්‍රධානී මේ අවස්ථාවේදී අපට දැක්වූ සහයෝගයට මාගේ ගෞරවනීය ස්තුතිය මේ අවස්ථාවේ පුද කර සිටිනවා. ඒ වගේම අද දිනේ මේ කාර්ය සාර්ථක කර ගැනීමේ උදෙසා මෙහි සාර්ථකත්වයේ පිටුපස සිටි විශාල පිරිසක් ඉන්නවා. විශේෂයෙන් අපගේ විධායක සභික උත්සව සංවිධාන කමිටුව මේ අවස්ථාවේදී එම කමිටුවේ සියලු දෙනා ඉතාම ගෞරවයෙන් සිහිපත් කරනවා. ඒ වගේම මම මේ අවස්ථාවේදී මේ ස්ථානයේ පැමිණි අපගේ ඒ සහෝදර ඖෂධයේදී සියලු දෙනා මේ අවස්ථාවේදී රජ ඖෂධයේදීගේ සංගමය වෙනුවෙන් මේ අවස්ථාවට මම ඉතාම ගෞරවයෙන් ගෞරවනීය ස්තුතිය පුද කර සිටිනවා. ඒ වගේම අපගේ මේ කාර්ය සාර්ථක කර ගැනීම සඳහා නන් අයුරින් අපිට සහයෝගය දැක්වූ අපගේ අනුග්‍රහයක බෞද්ධුන්ටත් මාගේ ගෞරවනීය ස්තුතිය අප සංගමයේ වෙනුවෙන් මේ අවස්ථාවේ පුද කර සිටිනවා. ඒ වගේම මේ අවස්ථාව මේ දේශන ශාලාව ලබා දීමට කටයුතු කළ මේ ආයතනයේ සම්බන්ධ සියලු නිලධාරීන්ටත් මාගේ ගෞරවනීය ස්තුතිය පුද කරන ගමන්ම විශේෂයෙන් සෞඛ්‍ය අමාත්‍යාංශයේ අධ්‍යාපන හා පුහුණු ඒකකය අපගේ මෙම ඖෂධ දිනය සැපරීම සඳහා නොමසුරු දායකත්වය සහ අනුග්‍රහය ලබා දීමෙන් අපට ලොකු පිටුවහලක් ලබා දුන්නා. සෞඛ්‍ය අමාත්‍යාංශයේ විශේෂයෙන් අධ්‍යක්ෂකතුමා සහ නියෝජ්‍ය අධ්‍යක්ෂකතුමා ඒ සියලු දෙනා මා ඉතා ගෞරවයෙන් මේ අවස්ථාව සිහිපත් කරනවා. ඒ වගේම උන්ට මාගේ ගෞරවනීය ස්තුතිය පුද කරමින් නන්නාවලින් මේ අවස්ථාවට සහයෝගය දුන් යම් කිසි කෙනෙක් අතපසුවීමකින් හෝ සඳහන් කිරීම නම් වශයෙන් සඳහන් නොකරුණා නම් කරුණා කාර්මිකව මගේ සමාව අයදමින් අද දින මේ කටයුතු සමාප්ත කරමින් පැමිණි ඔබ සැමට ගෞරවනීය ස්තුතිය පුද කරමින් මම නියැලෙනවා. බොහොම ස්තුතියි.
ස්තුතියි ගරු ප්‍රධාන ලේකම්තුමනි. 2023 වර්ෂයේ ලෝක ඖෂධ වේදී දින සමරුම් ප්‍රධාන වැඩසටහනයි මේ සමාප්තිය සිදුවන කරන්නේ. මේ සමගාමීව දිවයින පුරා විසිරී පැතිරී ඇති ඖෂධ වේදීන්ගේ සේවාව ලබා දෙන රෝහල් බොහෝමයක රෝගීන් දැනුවත් කිරීමේ වැඩසටහන්, ඒ වගේම රුධිර දන් දීමේ වැඩසටහන් ආදී විවිධාකාර වූ වැඩසටහන් රාශියක් ඒ රෝහල් වල ඒ පළාත් දිස්ත්‍රික්ක වශයෙන් රෝහල් වල ඖෂධ වේදී විසින් සංවිධානය කරා. ඉතින් රජයේ ඖෂධ වේදීගේ සංගමයේ පූර්ණ අනුග්‍රහය ඖෂධ වේදී සංගමයේ ඒ ලෝක ඖෂධ වේදී දින සමරුම වෙනුවෙන් කටයුතු කළ ඒ අනිත් කමිටුවේ පූර්ණ දායකත්වයේ KLM ඒ වගේම දියත ෆාමසිටිකල්, සෙලෙදෙන් ෆාමසිටිකල්, සියෝකා ෆාමසිටිකල් යන ආයතනවල අනුග්‍රහය ඇතුව මේ ආකාරයට ඔන්න සාර්ථකව සිදු කරනවා. ඉතින් ඊළඟට නැගී සිටිමු ශ්‍රී ලංකා ජාතික ගීය ගායනා කරමින් මේ කටයුතු ඔන්න සමාප්තිය සඳහා.
அடுத்த நிகழ்வாக தேசிய கீதம் இசைக்கப்படும். அனைவரும் விரும்புகிறேன்.
Namo
Without you, we could not have done this much of successful event. Please be kind enough to give your fullest support and strength to continue the development of our profession. We have come to the end of our session. Now you can have some refreshments. Thank you very much.